Patient who underwent bariatric surgery can or cannot undergo gastric or enteral tube placement. What are the implications? Considering that this patient, depending on the type of surgery that was performed, has a structural alteration. So, can it be done or not? And I'm going to tell a case report, which is very important, about what happened. When I started working, when I arrived, I was shocked by the situation. And to sum up, the patient passed away. I'll give more context about this towards the end of the video. By the way, don't forget to like, share, and subscribe. That way you'll stay informed and won't make mistakes. You'll keep learning a bit more with us here on the channel. Alright, shall we go? Guys, here's the thing. Let's go. First step, we need to understand that there are several types of bariatric surgery. I'm not going to explain any of them because that's not the main point of the video, okay? If you want, I can later give some context about the types of bariatric surgeries and what is done in each of them. After all, that's a medical topic, not a nursing one. We take care of the patient, we're not involved with the type of surgery, but there is something we do, especially in the emergency room. Emergency. It's the tube placement in cases of poisoning. The patient, for some reason, within a window of 1 or 2 hours. There is a need to perform a gastric lavage, then charcoal administration or something like that. And then, that's the question. Can I? Can't I? How is this done with my patient, okay? So, the first step, I want you to understand the following. Ideally, every patient for whom a gastric lavage has been indicated, that the medical professional has taken a brief medical history. Talking with the patient, if there is time. Why? This already helps in deciding whether or not to perform the gastric lavage. Why? When we talk about a gastric lavage, we were trained to do it, to perform a gastric lavage. Thinking of a patient with a normal physiological structure, that is, an anatomical and physiological structure, without any kind of alteration. Obviously, when we talk about the real world, where this alteration has occurred, and with each passing day, this is becoming more frequent. We have more people undergoing bariatric surgery. That's another issue, right? I won't get into that point, but this person comes to us as an emergency patient. When I say it like this, pay close attention. An emergency patient is not someone for whom you can think about option A, B, or C. No, emergency is emergency, unless it's not actually an emergency. So if something needs to be done, that should already come from the medical side. Already well detailed. In other words, if they asked us to do it, we expect that the medical team has already done this medical history. But if I were you, I would ask casually, okay? Have you had any kind of gastric surgery? Just so we can understand. If the person says yes, then you go deeper into the conversation. If they say no, that's fine. It's just because I'm going to insert a little tube and so on. I just wanted to know if you've had any kind of change to your digestive system, but it's fine, let's move on. It's not that you need to brush it off, you just don't need to go any deeper. But that's in case this person asks why you asked that question, okay? Or if a family member, a loved one, or a companion who already knows that person asks. So, pay close attention to this, okay? We expect that the doctor has already done this before, but it doesn't hurt for you, as a nurse who's going to do this procedure, to ask, yeah, but why? What could happen? We have two types of tubes, right? The Dobhoff tube will never be a gastric lavage tube because it's a feeding tube and it goes into the intestines. So I'll leave that for another video. But for gastric lavage, we use a Levine tube. And it's a tube with a more rigid structure. After all, it's a short-term tube, right? We insert it and remove it as soon as possible. And then we remove it. It's different from the Dobhoff tube. So what do we need to take into consideration? If this patient is actually going to have a gastric lavage, this tube, because it's a bit more rigid, depending on how long ago the person did it and the type, we might have some surprises, okay? During the insertion, okay? All right, so can the insertion be a problem? I'm not talking about the esophageal passage. I'm talking about past the cardia. In other words, after it enters the stomach and beyond. Because maybe that's where some anatomical changes happen due to the surgery. So, what do you do then? Do you know if it's in the right place for gastric lavage? Will you do it? How will it work? Also, another question. When we do a gastric lavage, we put a certain amount of liquid in, and then we stop and we do the drainage. We put in liquid, drain it, put in liquid, drain it, and so on. But now, if we don't have a stomach with the same capacity, then what? What volume are we going to use for this gastric lavage? Do you get the point? Because depending on that, a lavage might not even be recommended. Because if the stomach is smaller and you infuse a volume there to remove it later, but if I don't have, let's say, a storage capacity in the stomach because it was removed, modified, altered, this liquid is going into the intestines. And when it goes into the intestines, there's no way to remove it through the gastric route, right? So lavage really wouldn't be applicable. So thinking about it here, the patient then may be at risk because of the rigidity or the material of the tube. Lavage doesn't make much sense from a technical point of view because the amount of fluid you put in to remove would be much less. I don't know how much less it would be since it depends on the surgery. In short, you won't have time to, it's not like you can just do that. Let me give you a hypothetical example. You put in 100, take out 100, put in 100, take out 100, put in 100, take out 100. You get it? And another thing for us to think about. If there's a 1 to 2 hour window for gastric lavage, that's for people who haven't had any kind of anatomical alteration. And what about people who have had anatomical alterations? Does that window work for them too? Because here's the thing. In a normal stomach, we've studied physiology. We know a bit. We know that within 2 hours, the gastric contents have moved into the intestines. But what if the stomach is now biologically smaller? Do you agree that you don't have all that time anymore? From my point of view, right? I won't have the same capacity, but I also don't have that time. So, does this window of up to 2 hours also work for bariatric patients? What do you think? And another thing, if the person tried to poison themselves, you know what I mean? If she, depending on what she took, does it make sense to do a lavage? Since she has a smaller structure, it's already in the intestines where absorption is happening. So, wouldn't it be better to go ahead and use charcoal to reduce absorption in the intestines? So, these are things that we who work in the emergency room need to think about. I'll tell you a true story. I won't share too many details so I don't expose people who might be recognized if someone knows this story. I started working in an emergency room in 2012 and something happened. That horrified me, and it happened soon after I started working. A person who helped me a lot in the emergency room, who knew a lot and could handle things there, was someone who really supported me, and that's also where I started to become more resourceful myself. But I didn't know that this person was facing an internal investigation and another case elsewhere at the Corem. I didn't know, and I only found out when, let's say, the situation was resolved. So, to sum it up, what happened? A patient came in after a suicide attempt. The doctor ordered a gastric lavage, and she went to perform the gastric lavage. She had recently undergone bariatric surgery, and when the tube was inserted, she started to have hemorrhaging right there. And not to mention, she was finding the lavage difficult to do, and so on. Very little was coming back. Very little of what she put in was coming back. In short, she did the lavage the way she could. But she noticed that the patient was losing consciousness. He was going into shock. There was hemodynamic instability. And everyone was thinking, now, I don't remember, okay? I don't even know if they told me. But I don't remember which medication the person took in large quantity. So people assumed, okay, they took a lot, we did the lavage and all that. And she's having this hemodynamic instability because of the of the medication, okay? But when she was transferred to the intensive care unit, they noticed that she started having some bleeding. And when they evaluated her, she was having gastrointestinal bleeding caused by trauma from the tube. As if the tube was the problem, but she had just had surgery. So, to try to give some context, because, I got bits and pieces of the story, right? I didn't read. I didn't read anything, I just got bits and pieces. I was also very young at the time. I didn't understand much about this subject, but what did I understand? The person had surgery to try to lose weight, but was already very shaken psychologically, even before the procedure. I don't know what she was thinking about life. And she decided not to be with us anymore. And unfortunately, she ended up getting where she wanted, not because of the medication that she took in large quantities, but rather because of the procedure that was done to stop the medication. In short, the doctor was held accountable, and so was the nurse. The hospital was held accountable. However, she didn't lose her nursing license. The Regional Nursing Council conducted a full review. She saw that really, given the conditions there, she did what she had to do. She didn't lose her nursing license. I think it's unfair, okay? Not because she was a good person, but it's because, man, in the emergency room there, if you don't have much information, especially since it wasn't that common, not like today, this was in 2012. This video is being published in 2025. 13 years later, how many people 12 years ago did you know who had undergone bariatric surgery? Not today. Today it's more common. So, here's a warning for those of you who work in the emergency room. We're creating a postgraduate course in urgent and emergency care. Our postgraduate course will feature many real cases. Exactly so that our emergency specialist nurses, the emergency professionals who will study with us, will have a better grasp of real-life situations and be more in touch with the changes that have been happening. All right? So keep an eye on our IPS, which is the Instituto Prático de Ensino e Saúde, because we're going to launch a postgraduate course next year in 2026 focused on emergency and urgent care. Stay tuned, all right? Thank you.